Good morning all. I'm presenting a case of a 62-year-old female who came with complaints of diminution in vision in the left eye since 1 month, last year January. She had a history of no systemic comorbidities whatsoever. On examination, the anterior segment was okay, right eye was totally okay with 6/6 and 6 vision, but the left eye had 6/36 and 12. The clinical picture was showing a full thickness macular hole in the left eye. OCT also revealed a macular hole with base diameter of 616 microns horizontally and 539 vertically. So she underwent vitrectomy with ILM peeling, the standard procedure, fluid exchange with 20% SF6. But after 1 month, the hole we saw persisted and the basal diameter was a bit increased, 891, 700. So we decided to go for a re-surgery FA with re-gas injection, preferably a C3 FA this time. But the patient refused. The patient was not willing for the surgery at this stage. So we asked the patient to wait for at least 2 months and then come back and then maybe reconsider again the surgery. Patient was lost to follow-up after that. She came in November directly. With further drop in vision, the cataract had increased a bit and the vision dropped to finger counting 2 meters and 36. And the basal diameter was holding on, but the macular hole was also maintaining, persisting at that stage. So we went ahead with the surgery this time. Patient agreed. So we explained to the patient that we have to do the setting at the cataract surgery and the in the same setting. So the patient agreed. So after removal of the cataract, we entered in the posterior segment, securing the infusion line. And I started staining. I stained the ILM for any residual ILM which would be still attached to the macular hole edges, but to the failure I found that nothing was attached. So I started taking and peeling off the nasal margin, the nasal ILM, and I was wanting to do a superior flap and invert it over the hole, and kind of like leaving a flap over the hole, but then I couldn't grip it properly. So I started extending the same nasal edge towards the temporal periphery, and at this stage I experienced this surgical snag, which kind of stopped me, and I got frozen at that stage. That now what to do next? And at this stage I had to hand over the case to my mentor. So then he took over.
Okay, good morning all. So firstly, this is a re-surgery case. The first OCT, as we all have seen, had a good visual prognosis there. That is, the hole closure chance was higher. But even after surgery, the hole had not closed and the patient was a bit difficult to manage. So we had to talk to her. We convinced her that she requires a re-surgery with a re-gas injection. But she wanted to wait for some more time. So by the time she came back, her cataract had also increased. So we explained to her that the defective vision is mainly now due to the cataract also. We'll have to remove the cataract. So better to go for a single procedure, that is cataract with re-gas injection. During the procedure, what we planned was that since it was a re-surgery, we definitely wanted the hole to close. So we decided we would try for a superior flap. That is, instead of stuffing something into the hole, we wanted to keep in the ILM itself. So we decided for a superior flap, to try out a superior flap. So, but during the surgery, also we wanted to see if there were any remnant ILM that was there remaining in the edges of the hole, but that was not there. The previous surgery, the ILM peeling was good. So while trying to get a superior flap, we had a retinal hemorrhage. So this is our super safe. What we did was that I asked him to increase the intraocular pressure immediately to 60 millimeters of mercury, which he had done. So that helped us in controlling the bleed a bit, and then we extended the flap a bit more temporarily. And then what we did was that we did a fluid air exchange, and usually we drain over the disc or near to the disc. This time what we did was that we drained it inferiorly, so that the free flap that was there on the retina would fall eventually along with the fluid over the hole. So after that I closed up the eye, and after injecting gas I closed up the eye. So this is our super safe. We increased the intraocular pressure so that the bleed gets controlled, and then using the flute I drained the remaining fluid inferiorly so that the flap gradually fell over the hole. And miraculously, our hole had closed in 1 month post-op, and she had an increase. Her visual acuity had increased to 6/12, and the hole had a type 1 closure also. And the patient was also happy, and we were also happy. Thank you.
I thank Dr. Shivanker and Dr. Vishak Kumar for this fine case presentation. Over to you, judges, for the panel discussion.
Very well done, that's all I can say. As far as I know, it's an innovative procedure. I don't know much more than that, but very good results.
Yeah, it is very well done. So, failed macular hole surgery, you would want to put an ILM flap on that from somewhere. So, either it can be from the superior one. You can take a flap far away and then tilt it on, or a free flap. Free flap will be extremely difficult because with gas it will just go away, or a flap of something else, maybe some other material also, including amniotic membrane or a capsule, which you could have preserved in this case, or something like that. When you do the ILM peeling, it is sometimes, especially earlier on, there could be a small vessel rupture, etc. And with heightened pressure, we can control the bleed, and in some cases you may require to tamponade it with some agent, or maybe in some cases with more bleed, probably you may have to diathermize also slightly. So that is a learning curve that all young retinal surgeons will go through. Thank you very much.
Dr. Priyanka Jadhav, she is a PR Fellow at Giridhar Institute, Kochi, and her mentor, Dr. Anubhav Goyal.